Hi, it's Dr. Noel Williams, Optimal Health Associates, Oklahoma City, Oklahoma, with Merlin. Hey, Merlin. Hi. Merlin's going away now, though, because he's the crazy 11-week-old pup. But anyway, hi. I hope everyone's good and had a good Christmas weekend. So I did. We just hung out at home. I hope that's what most everyone did because it is not the time to be going out. We're ranked number one in Oklahoma, unfortunately, for test positivity for the week of the 20th through the 27th or 26th for those 7 days in the nation. That's a little scary, especially since our testing is down. And so I'm not saying, and the testing going down doesn't mean that it shifts the denominator down. It just, the numerator and denominator, or the top half of the fraction and the bottom half of the fraction numbers are what they are. But since we're testing less, we're catching less. And we're testing less probably because some of the funding for the labs has gone away and maybe some of the supplies. But it's very concerning to be the number one state for infectivity relatively per person or per capita in the United States, and we're going to come some of the other top measures for seriousness. Some of the regions in the state, and there's 8, I think, regions as defined by the state health department, are in tier 4, the worst scenario, with over 40% of the hospital beds filled with COVID patients. So for the next month or month and a half, I would really encourage everyone to be smart. I think this weekend coming up, and by smart it means wear your mask, and don't do unnecessary activities. So if you have big New Year's plans, that's a huge mistake. Going to bars is a huge mistake. And I'm really sorry about that for all the bar owners, but this is a public health thing, so I'm sorry. Again, limit your restaurants. Restaurants should be following the guidelines that are still in place from the governor. And I would just encourage everyone to be smart and be safe. We can't be doing our normal activities right now. The hospital situation is pretty dire. The Integra system had a record number of people in the hospital as of this morning. I think it was 297, and that's with 9 people dying yesterday. And so our death rate is definitely going up in terms of the numbers of people we have. In the United States, we're at 343,000 dead. We're going to probably crest into 350,000 the next 2 days, 3 days at the most. Well, on our way towards 400,000 and then 500,000 by the end of January at the rate we're going. So it's all kind of a bummer, but what can we do about it? Well, it's the core stuff. 1, take your vitamins. I mean, it's just anecdotal. My impression is our patients seem to be doing very well who get it. We have lots and lots and lots of, again, stories from people who did their zinc and have been on their vitamin D, and there's now data showing, once again, the vitamin D and zinc work, that people do better. So zinc, your vitamin D, you have to be doing fish oil for blood clot protection. If you're not doing fish oil and you get COVID, call your primary provider and see if you should be on an aspirin. If you're a high-risk patient, you should probably most assuredly be on aspirin. But again, you have to talk to your doctor. I'm just giving you a ballpark picture of what you could do. Post-COVID infection blood clot is a big issue, and I don't think I don't know necessarily if it gets the emphasis it needs to get. You need to be on your multivitamin and your melatonin. And that's your core stuff, basically. Zinc, vitamin D, multivitamin, melatonin, and I know I'm missing something at this point, and your omega-3, and that's your core stuff, and I've listed it a ton of times. Now, in terms of what we're doing for people we see who are infected, we've really switched up to ivermectin. We're having, again, our results have been they're anecdotal, seem to have been very good so far out of about 25 people. I mean, I spent the weekend, I treated starting on the Wednesday before Christmas and through today, just myself in my practice, I treated 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, I think 13 people, just myself. And that's not including my team of nurse practitioners and PAs who all either treated active patients or exposed patients. So it's really out there, and so just be careful. We've had good results with the ivermectin. We've gotten a lot more aggressive with the steroids because we've had several patients get ground glass changes in their CTs and had more pronounced or prolonged respiratory disturbances, even with mild infections, and that's again what the data is showing. So I think COVID is a big deal, even if it's a mild infection, and you really need to watch your pulmonary symptoms and communicate with your doctor about steroids. So anyway, the details of how we manage it's how we manage it, but you need to talk to your primary care. And that's the big thing, is communicate with your primary care. Take your supplements, stay at home as best you can, wear your masks if you go out, use your hand sanitizer, and we just got to get through the next 6 to 8 weeks. Vaccine update. So far, I think the vaccine's been extremely well tolerated. People do get a little flu-like symptoms. Some people do get some mild reactions. None of the reactions, as of last week before Christmas, none of the reactions required hospitalization. There had been a couple that had gone to the ER, and that had been about it. And that's with, as of Tuesday, it was like 30 or 40,000 vaccinations. So again, it's very well tolerated, and the data is really good. It's how we're going to stop the hospitalizations and the infection. So, that's just how it is. Kim, what questions do you have?
Well, first, you brought up the ground glass in the lungs.
Okay, so one of the things we look at after people have COVID, if they're having persistent respiratory, like some shortness of breath, they can't catch their breath, they're having pain with inhalation, is we'll do a CT of their chest with contrast. One, because sometimes we're thinking about a pulmonary embolism or a blood clot being in the pulmonary artery. The other thing is we want to see what do their lungs look like. And so one of the thing that's pathognomonic in part for a post-COVID infection damage to the lungs is ground glass, or like it looks like there's ground pieces of glass in the lung windows on the CT. So we've had 3 people with that so far. 1 with moderate outpatient illness, 2 with mild outpatient illness. And what those little ground glass spots are, it looks like from histology or looking at postmortem autopsy slides of people's lungs who had that, is it's a little ball of dead lung cells with lots and lots of inflammatory cells inside of it. And so you get those scattered throughout the lungs from the massive amount of infection. And the problem is sometimes people are having a massive lung infection from the COVID without having the symptoms of it. You hear about people who have really bad symptoms and they go to the hospital and their oxygen falls, but there's other people who just get that damage without getting sick enough to go to the hospital, and then they're going to potentially have long-term lung damage. So that's with ground glass on CT, and it's, again, pathognomonic means the pathology or what you're seeing names the disease process, and so it's pathognomonic for COVID. Anyway, go ahead, honey. Next.
You had some questions about the vaccine. Will zinc inactivate the vaccine?
No, nothing you do inactivates the vaccine. So there's 2 vaccines out, the Pfizer and the Moderna. Both are very consistent. There's very good data on them. So the Pfizer one logistically is harder to get out because it has to be maintained at negative 70 degrees Celsius. And then once it thaws, it has 5 days of use. The Moderna vaccine does not, so it's easier to deal with. Both are thought to be very, very effective. Fauci did the Moderna, and so other people in the CDC did the Pfizer. So I think they at least feel consistent with doing them. I've looked at the data. I think that at this point where we are, you need to do the vaccine. I've gotten my vaccine now, and you just have to look at it like, do we want to get vaccines urgently? No. Do we want to end up in the intensive care unit? No. And so it's just a matter of risk. Now, I'm not recommending the vaccines for people under 18. I don't really think there's a big role for them for healthy people in their under, I don't want to get in huge trouble with everyone, but people really at low risk under 25. But I think then the whole question, should you get the vaccine if you've already had it, is, I'm not even going to go there because that's way too complicated and controversial. But I mean, if you look at the average at-risk person who's over 25, it's a great idea to get it. If we want to get herd immunity, the 18 to 25s, it's probably useful. But again, I think You just got to look at your own risk factors and decide, but I would strongly encourage everyone to get the vaccine who's eligible for it. So if you're in healthcare, you have multiple medical problems, you're a teacher, you're a firefighter, anyone who's dealing with the public on a consistent basis, you don't want to get COVID and be the ones who get hospitalized. So I would get the vaccine. Right? It's pretty simple at this point.
So with the vaccine, what about the conversations about birth defects or fertility issues?
There's no data showing birth defects. I think there was 8 people in the Pfizer study who got it. There was no problems there. I don't have the Moderna data. By its very nature, though, that a messenger RNA vaccine is going to be processed in and out of the body pretty quickly. That's kind of how they work. So I don't have any big concerns about that at all. I do have concerns about pregnant women getting COVID because we're seeing right now both, one, a significant increase in illness and pulmonary deficiency and critical illness in pregnant women. And the other thing that's starting to pop in terms of data, unfortunately, is stillborn, and miscarriage may be going dramatically up. That's still new data, but it makes sense because pregnant women are the most likely group to clot because they have high amounts of estrogen, and that makes the clotting proteins go up just naturally. Then they also have venous stasis, meaning there's less blood flow speed per se because you have that big uterus pushing against the big blood vessels in the abdomen, which slows the blood down, and so that leads to an elevated risk for clot in general. And so then you add inflammation from COVID, which causes a particular increase in clotting proteins. And for those of you who want to know, the thing that really goes up, it's interferon gamma, and interferon gamma goes way up when you're infected. And so that leads to microemboli. Microemboli can, give pulmonary embolus and stroke, but it can also pick off the parts of the placenta and cause miscarriage or stillborn. So again, big subject for pregnant women. So pregnant women need to be particularly careful and be on all their supplements and their fish oil.
And there was a question about one of the ingredients in the vaccine, and I may say it wrong, but hydroxybutyrol?
Hydroxybutyrol is just an agent that's used in vaccines. I will have to look that up more, but it's been a very standard thing in vaccines. It doesn't have mercury in it or anything like that.
Okay. And then, so not vaccine. If your family has had COVID and recovered, is it safe to go around their father, who's in this case is 66? Can they go around the father? Can you still be contagious? Can you still be a spreader? And what about the new strains? Should they worry about that even though they've had this one?
So that's a lot of questions in one. So the first thing is, if you've gotten COVID and you're more than 10 days out from the initiation of your symptoms and you don't have a fever for 24 hours, you are not infectious. The only exception to that is if you're on chemotherapeutics for cancer, then you're in a totally different ball of wax, and we're not talking about those people. If you are a cancer patient on chemotherapy and you have COVID, you could be infectious for up to 30 days to 60 days, depending on the worst case scenario. So you would need to talk to your oncologist about the ramifications of how long you have COVID and could be infectious, but minimally I would say 30 days. If you're not in that group, it's 10 days. And so at that point, day 11, you are not infectious. You can go around family members or other people or go back to work. Number 2, what was that other thing? The new strain. We don't know yet. The new strain is the new strain. So far, the initial review doesn't mean that it's a new strain in terms of infection to people who've had it. There is no clearly established strain at all that causes reinfection, period. That would probably be out now in England if that was going on. They would have a lot of people who were previously infected getting reinfected with the new strain. There's been no data showing that. So the new strain just means it's COVID, but it's a little different. And its little difference is it can infect a little easier. It doesn't mean that if you have prior neutralizing antibodies, they're not going to protect you from either the vaccine or potential prior infection. There's big debate about prior infection immunity. I think very clearly there's 3 months of immunity from prior infection. I think it's highly unlikely there's not 6. And I think it could be very, very highly unlikely it's not 9, 12, or 24 months, depending on how sick you got and your immune response. But it's not your antibody levels, it's your B cell activation and memory in your bone marrow. So that's really what matters. So for a normal person, you're going to probably have some protection long term. Does that mean you shouldn't do the vaccine? Well, I kind of equivocated to shingles. I had chickenpox when I was a kid. I've not, knock on wood, had a shingles outbreak yet. But you can, so you get the vaccine to inactivate it, or not inactivate it, or to make it more antibodies to keep it inactivated. So some people have that happen, some people don't. COVID may be like that. We don't know yet. But the general trend is people don't, get reactivation. And I ought to be careful here. I don't want to give too much theory. But the bottom line is it's highly unlikely in the first 3, 6, or 9 months you're going to get reinfected, because there aren't people getting reinfected. Okay, it's not happening. There's these isolated case reports, and that may be possible, but it's still not good data saying there is. So that's my view of it. And I could be wrong. I want to be clear, but so far, it is what it is.
There were a lot of questions about Invermectin. I don't think we can get very specific on that. People wanting dosing.
I can't do dosing or specifics on Invermectin. You have to talk to your own doctor about it. You can look up online the Indian study on Invermectin for prophylaxis. You can look up online, and you don't even have to go to PubMed. You can just do literature search, or you can just do a Google search on Invermectin for treatment and what the dosing is and stuff. But you're going to have to get someone to write it for you or find it or something. But again, I'm not suggesting that. I'm suggesting you talk to your provider about dosing. And hopefully they'll take care of you. That's their job. And again, I know the providers get a lot of grief about having or treating people, but you know what? This is the one thing I'll say about that. We went to medical school to take care of people. This is when we've been the most needed in the last 50 years, period. So being unable to treat people because you're scared or something and you're worried about your malpractice insurance, I have no sympathy for. At a certain point, if you're a primary provider like I am, you have to read the literature and make a decision. Do I take care of my people, or do I just let them get sick and see what happens? And each doctor or nurse practitioner or PA has to make that decision themselves. And that's my view. I've made my decision. We treat our people. And I know other doctors who've made that decision. I know other doctors who haven't and won't do it. But hey, it's how it is. So that's it. Good night.